Okay, I'm going to tell you up front, I'm lazy, naturally, okay? I've gone on and taken a position at the Amniotic Fluid Embolism Foundation. And so I was preparing a lecture that was separate, but the AFE Foundation really is trying to have a central message to the lay public, to professionals. And so in keeping consistent, I called my good buddy, Gary Dildy, and I said, Gary, you just did this great talk at the Society of Maternal Fetal Medicine, Critical Care Stimulation on AFE. So I said, send me your slides. So what I'm going to do, I'm using some of his slides, some of mine, and I'm going to make it Dave Adair's, Gary Dildy's talk, okay? So I'm telling you up front. Disclosures, I'm the chairman, founder, and chief science officer for Glenveigh Medical, which has patent rights and royalty rights with clinical innovations for their product called EB, which is out there. It's a hemorrhage device. Has nothing really to do with the talk today. I'm also a major shareholder in Velo Bio, which is a company that's working on a phase 3 drug for preeclampsia. It's a biologic. We won't be talking about preeclampsia. And I am a board member for the Amniotic Fluid Embolism Foundation. So we're going to try to talk a little bit about background, the incidents, how you diagnose this, the pathophys, how you treat it, where we've been, where we're going to go. Our objectives today will be to recognize a likely clinical scenario for amniotic fluid embolism. And before we go any farther, let me remind you, for some of you are old enough to remember this was amniotic fluid embolism, AFE. Then we were kind of like Prince. We wanted to change our name. We became the anaphylactoid reaction of pregnancy. That didn't catch on, so I think Prince is back to being Prince, and I think we're now back to being amniotic fluid embolism, or AFE. So I just want to make sure to clear up any confusion out there. Say, well, I thought that was this and this. Okay, AFE from here on out, okay? So we'll go through the differential diagnosis because it can be very difficult to diagnose, and I'll prove that to you. Look through the morbidity and the mortality. Most of the things that we've talked about today has been really concentrating on morbidity, a little bit more on the neonatal mortality. What we're going to talk about here is really both maternal and fetal neonatal mortality. This is a disease that has killed women for a long time and even today still continues to do that. And then talk about some skill acquisition that can enhance hopefully a better outcome for you and your patients. So the first medical literature report of AFE was in a Brazilian journal. Now, these are the people who gave us wax jobs to make this look good. They've given us more recently the Zika virus, okay? And they're going to be hosting the Olympics this summer. So you can go get waxed, get infected, and hopefully you don't come back with amniotic fluid embolism. And that was in 1926, okay? 1926. The next paper was almost 25 years later, in 1941, by Steiner and Lushbaum, pathologist, okay? Now these are some partying dudes. You want to hang out with some people that want to have fun? Not pathologists, okay? We get medical students, I can always tell when they walk in, pathologist, okay? New personality, okay? So they presented several cases of unexplained death, and they had done autopsies. And this is where the AFE kind of comes from, where they observed amniotic fluid cells, fetal squames, and the pulmonary vasculature and the lungs of these expired patients. So in 1941, this concept got basically put forth. So, since then, what have we done? Well, if you look at the literature recently, there's less than 1,100 actual studies, okay? And I'm going to use that word loosely, okay? 1,100 studies. These aren't real studies. Most of them are case series or a case report, discharge data from hospitals, large databases, statewide databases, mortality review teams. Few animal studies in there to see if we could mimic, create a model, etc. But long and short to it is this: we don't have a lot of good information. Okay? Why is that? Is that because we don't do a good enough job or not interested in it? That's not true. It is a rare, a very unfortunate and catastrophic an acute event that you can't prepare for. Okay? In terms of preeclampsia, in that same time period, there's well over 35,000 citations for preeclampsia, because preeclampsia is something we see, we can manage, we can diagnose. AFE is largely a clinical diagnosis. There is no gold standard. Okay? There's not a lab test, there's not a clinical finding, etc. It's a bunch of symptoms you have to exclude to finally arrive at that. Okay? So it's a syndrome, a true syndrome. So classically it's thought of as having the three-legged stool. Okay? Hypoxia, hypotension, or massive cardiovascular collapse. And then ultimately, if you survive that, a third stool is the coagulopathic process that then ensues. Now, there are probably several different presentations for this. There are reports of some women having just a development of an isolated coagulopathic process during labor without the other accompanying symptoms. So, maybe that's an AFE, maybe it's not. But the classic triad is the one that we hold time and true. It is, again, this is the most important thing for you to take home if you take nothing else with you. It is very poorly understood, unpredictable, rare, acute, and it lacks a gold standard definition. Okay? I'm not Marco Rubio, okay, so I'm repeating that for a reason, because it's very important. We have a lot of work to do. And again, it can be multiple factorial in multiple presentations. And then in 1948, this is probably the most profound statement of anybody, since Cragen said, once a cesarean, always a cesarean. 1948, Eastman said, let's be very careful not to lump all unexplained deaths in obstetrical patients into a category of amniotic fluid embolism. So you fast forward, I guess, what is it, 67, 68 years later, I'm going to challenge you to make sure that we don't do that in 2016. Yep. So it's reported to occur at about 1 to 8,000 to 1 in 80,000 deliveries. And this is mostly retrospective data, discharge data type data. Originally it was thought to have mortality approaching 90%. Okay? More recent studies, the last 2 decades, said a little bit over 50%. And probably more contemporary data would suggest that it's less than 50%. But I would submit to you that anything, when you're talking about maternal mortality, that's a flip of a quarter, is still unacceptably high and gives us reason to study. If you look at the HCA database, which is probably the best delivery data system that in the world right now, they do about 250,000 deliveries a year. They did a 7-year analysis, and they found that amniotic fluid embolism was in the top 3 causes of maternal mortality. In fact, it was number 2. And in most common peripartum death worldwide, it still is very, very highly contributing to that. Looking at retrospective data from developed countries, undeveloped countries, etc., Austria, Canada, Netherlands. In the Netherlands, they have great databases there. And you look at those databases, it's about 1 in 17,000. When you use a very selective screening process with validated data, that incidence goes to 1 in 45,000. So Gary is always a back of the envelope kind of thinker. And so if you look at the discharge databases and that discrepancy between using standard accepted nomenclature and a screening system, about 60+% of that discrepancy is explained by the fact you have false positives represented in that. So the true incidence is probably more around 1 in 30,000 to 1 in 40,000. So, now, if you look worldwide, again in developed countries, it's anywhere from the low single digits all the way to 30+% in terms of contribution to maternal mortality. This is the HCA database I was telling you about. This is about 1.5 million women. What's important about this particular one, where's the pointer? Did David Lewis steal the pointer? Or did Brenda Snowman hide it from Dr. O'Brien? Okay, I'm going to see if I can get a seizure going. Sorry, John. Wait. We love you, baby. So if you look at the HCA database, it does keep me awake, John. It always does. Okay, so if you look at the database, the top three things are preeclampsia, amniotic fluid embolism, and obstetrical hemorrhage. Obstetrical hemorrhage is number 3. And their analysis, about 2/3 of those women who died could have been prevented. Preeclampsia, a good majority of those women could have had aversion to their death. Okay, so those are 2 areas where we can make improvements. And again, because it's more frequent, more common, we can anticipate those things. Amniotic fluid embolism cannot be prevented, predicted. And when it happens, that's when we can make some improvements. Okay? So it was the number 2 cause, 14% of deaths in 1.5 million patients. So big contributor. Okay, any Tennessee Vols here? Yeah, all right, there we go. So you notice the orange, right? That's a Dave modification, in case you're wondering, okay? These are 2 large databases, okay? They're registries. This first one is the U.S. registry that Steve Clark, who, by the way, Steve is probably the most prolific investigator in this. He's written numerous articles. The one I would tell you to go cite and commit to memory is the one in the Green Journals a few months ago. He did a very nice invited review and summary of the evidence, and I think that's probably the best one to do, and you get some CME for it as well. The second one is a UK-based, using the same diagnostic criteria, very strict criteria, done in 2005, so a decade apart. The open bars are those who survived intact. The checkerboard from Tennessee, those are the ones who had some impairment when they recovered. And then the solid orange is death. Okay? On the first part here, this is maternal outcomes. 1995, you can see that's roughly about 50+% were dying from amniotic fluid embolism. If you survived, there was a good 25% who had significant neurological poor outcomes. Okay? And only about a 20% intact survival. You fast forward in a decade using standard registry definitions and correspondingly improvement in care, okay, particularly critical care access, etc. You can see from the UK database, the mortality significantly reduced down to around 30%. Those who survived and had long-term neurological outcomes, significant reduction, about 10%. And you can see about 60% had intact survival. Okay? On the neonatal / fetal side, you see a similar pattern. Okay? So we are making differences. Okay? And there's an individual here today that I think has done more to help promote that difference, and I'll get the chance to introduce her in a minute, but I think we are making strides towards getting things better. So if you look again worldwide, as high as 86%, down to as low as 11%. But I think in developed, well-resourced type countries, we should be somewhere around 30 to 40%, certainly less than 50%. So the pathophysiology. What we believe, okay, there's no hard concrete data that says this is absolutely true, okay, but this is our current concept, is that somewhere during the delivery process or the peri-delivery process or immediately post-delivery within 30 minutes, there's an exchange of fetal placental tissue into that special place, okay, between the decidua and that maternal fetal interface. This tissue, okay, which I'm going to tell you happens on every single delivery, but there's 1 in 100,000, 1 in 50,000 women, for some reason, react to that exchange in an inappropriate way. That's not a conscious thing, okay? But this is just an idiopathic type reaction. Almost think of it as like a anaphylactic reaction to a bee sting or some peanut butter or, eggs. And I've got kids, you can tell I got some kids still in preschool and middle school stuff. You can't have certain foods at those schools, okay? So it elicits a response that is very similar and characteristic to systemic inflammatory response syndrome, or SIRS, which can be accompanied to sepsis. Okay, John, now I've really fixed it for you, okay? Apparently we've locked it up so you will not be able to induce any more seizures, okay? So take my word for it, sepsis and anaphylactic reaction. which leads to a massive outpouring of an inflammatory response, what leads to coagulation, okay, consumption of the coagulative factors. And it's basically like having a bank account and you go shopping. You only got so much. Once you spend it, you're in the hole. You only have so much coagulant factors. Once they get spent, if you don't replace them, you're into a free bleeding state, which then releases an endogenous mediator response. Vascular perturbations occur, and you get multi-organ dysfunction. And then ultimately, what we know as clinical manifestations, hypoxia, massive cardiovascular collapse, and then coagulopathic process. So early on, this is usually from the time, and a lot of women will tell you they're having these symptoms that are kind of a premonition, if you will. Okay? I don't feel right. Something's not right. I have this impending doom. Okay? Those are things that actually have been born in the literature to have some predictive value. Okay? That's in that first 15 to 30 minutes. Typically what happens, you have hypoxia, then you have a massive outpouring, you get systemic hypertension and pulmonary hypertension. Okay? Once you recover from that, pulmonary artery wedge pressures usually go back down to normal, and you got florid left-sided failure. Okay? So it leads to myocardial depression, myocardial infarction, poor perfusion, brain injury, kidney injury, etc. Okay? So that's kind of the process, and it's very similar to what you see in SIRS, etc. So this is just a wedge diagram on the Y prime. That's the left ventricular stroke wedge index. That's how good the heart's squeezing. On the bottom is the pulmonary capillary wedge pressure. And you can see where the stars are. Those are where these people end up who get central monitoring once they've survived the incident. So this is the predominant hemodynamic perturbation that you see in most of these women. Okay, so let's talk about the coagulopathic process, because this is an interesting thing. We've done animal models with very inconsistent results. Okay? Some animals we've been able to mimic the AFE process. Some animals we haven't. We've given more inoculum of amniotic fluid embolism to animals than you would ever get. Even if you took a whole uterus and inoculated a mother with it, it hasn't caused a problem. So clearly, that's not the whole story. If you look at in vitro studies where you play in the test tubes, amniotic fluid is shown to shorten blood clotting time. It has a thromboplastic effect, okay? So it promotes a clotting ability. Okay? So you start to consume those clotting factors, which you only have so many of. Remember that. Platelet aggregation, thromboxane release, platelet factor 3, factor 10, and then you're into the complement cascade, and you got a massive outpouring of perturbations on multi-organ dysfunction. Okay? So if you look at that, you say, okay, well, that may all make sense, right? Well, when you actually measure all those factors that's in the amniotic fluid, and then you look at a thing called tissue inhibiting factor kind of keeps those things in check, okay? So we have more tissue inhibiting factor in the amniotic fluid, and so that's the reason why we probably don't see more of this than we do. Thank goodness that the good Lord knew to put the TIF in there, okay? So we're left wanting more. As we ask more questions, we learn more, but we still want more. This is something that I think is kind of interesting, because remember we said the pathophysiology mimics an anaphylactic reaction, a SIRS response, a sepsis response. This is from Roberto Romero, where Roberto sticks needles in anybody who'll hold still. Okay? True story, I was actually interviewing for fellowship, and I was actually in the bathroom, just standing at the urinal, and Roberto amnioed me. I mean, it was amazing. Yeah. I'm joking. But Roberto has stuck a needle in probably more women than there are women around, okay? I mean, they do this. But they're looking for inflammation largely in preterm birth, prom, things that we've been talking about. And a lot of the elegant studies that our speakers have been talking about today come from his work. Okay? And these two women he found a pro-inflammatory factor, okay? Tumor necrosis factor alpha, the old Cooley's toxin, okay? This was just serendipitous. He had amniotic, got the level, and then these women had massive amniotic fluid embolisms. So clinically, these women were stable, no problem, had very high levels of this, unbeknownst to anybody. They had AFE, and they died. So this is an interesting observation. We're not ready to hail this as the cure-all, and this is absolutely what it is, but I think it supports that general concept of the pathophysiology. Now, those of us in the room who are old enough to know what Pitocin and oxytocin is, right? There's always been this finger pointing at oxytocin being the culprit in this, okay? Because it causes tumultuous labor. A lot of women who have this, if you're monitoring them, they'll have this big tetanic contraction. Then they have the amniotic fluid embolism, okay? Well, physiologically, that doesn't make sense, okay? Because there's bazillions of women who get oxytocin, okay, number one. Number two, when you have a contraction, what happens to that elegant villus transport system, okay? It gets shut off. All the spiral arteries get shut off. So there's absolutely nothing moving to the maternal circulation or to the fetal circulation, okay? So that would be the absolute worst time to try to put something across, okay? You need to have the uterus relaxed in order to get something into it, right? What we believe this represents, okay, is in that surge type response. This is a massive outpouring of norepinephrine that causes that contraction that probably precedes or is a precedent or maybe even superimposed on the clinical development, okay? So it's probably the egg and the chicken. I'm not sure which one this one is, but it's probably before and probably just an innocent bystander. And if oxytocin does contribute, it's going to be in a very, very minimal number of cases. So still safe to use oxytocin, probably in lower doses, not because of AFE, but you get better outcomes, okay? Induction of labor, okay? There's a lot of finger pointing at this one, okay? There's several studies that say yes, several studies that say no. And I know most of you who use MFM, when you get one of us, we give you how many different answers? Right, 10? Okay. I think there's about 6 or 7 or 10 of us in here, so that's at least 100 answers you can get on this one, okay? So if you don't like the study, we'll just do another study. That's the way this works, okay? So this is mostly retrospective data, discharge data type studies from Canada, the US, and the UK. So we'll call those the big three, okay? Kramer in Canada and Knight in the UK said, yes, induction of labor causes this. The US compadres here said no association, okay? Millions and millions of people get induced every day, okay? Usually it starts with seduction, right? That's about 9 months early, right? Then we have an induction, okay? Then after the kid screams a lot and stuff, then you get divorced and you have a reduction, okay? Of course, now I'm seeing mommy makeovers and I'm thinking that's the reduction part, okay? And the good news is the government has looked out for you. They'll give you a deduction, okay? So a lot of actions going on here, right? So in these studies, okay, given how common we do induction of labor and how uncommon amniotic fluid embolism is, if in fact there is an effect, cause and effect here, it is probably minuscule, okay? So you can still do your inductions just after 39 weeks, unless they're indicated, okay? And let me say that another way, okay? If you have a 24-weeker with HELP syndrome, no, you don't have to wait to 39 weeks, okay? These are on the unindicated deliveries, okay? What about prostaglandins, okay? The story I just told you about induction holds true. We use them. They're very safe. They're endogenous, okay? However, let me tell you about this. Once again, our government is looking out for us, okay? They have put into the package insert of the 2 commercially available products, okay, Prepidil. Nobody over 40 gets to answer this. Anybody under 40, have you seen Prepidil? Do you know what Prepidil is? Okay, I know. It's okay. Well, the old Prepidil was great because it was like a mafia hitman. It had all these screw-on attachments, and you had long ones, you had fat ones, you had short ones, and then you'd have to put a speculum in, and you had to do it every 3 hours and squirt this stuff as prostaglandins. Women hated it. So then somebody got smart and put the same stuff into basically a tampon, okay, which was cool because once you squirted this stuff, you know, whatever happened, happened. With the tampon, Cervidil, you could at least pull it out, okay? But the government in 2009 asked them to put in the package insert, and I'll quote to you, both of them had the same thing. The clinician should be alert that intracervical placement of dinoprostone gel may result in inadvertent disruption and subsequent embolization of antigenic tissue. Does that sound familiar? Pathophysiology. And causing rare circumstances the development of anaphylactoid syndrome of pregnancy. And this is when we were trying to make our change, right? Okay. And we put parentheses because Prince used to put the sign and then he put, formerly known as Prince, okay? So formerly known as amniotic fluid embolism. I don't know that they've updated it and done away with the anaphylactory thing and just AFE, but suffice it to say there is a warning there, okay? Again, we use this on all kinds of patients, very, very safe medication. If there is an association, it is a very weak association at best. So the diagnosis. Using strict criteria, the UK obstetric surveillance system has come up with a suggested algorithm when you evaluate a patient who presents with these kind of symptomatology. By using this, we're going to actually be able to tease out what we call false positives and really get to the crux of the matter, okay? And it's a very selective criteria. So in order to get into the AFE registry that Dr. Clark did in 1995, you had to have an acute hypertensive event and or a cardiac arrest, acute hypoxia, the development of coagulopathic process, and it had to occur during the onset of labor, delivery, or 30 minutes after delivery. And you had to have an absence of any other explanation. This is the West Virginia, because I'm from West Virginia, we're not real smart, so I try to keep it simple, stupid. This is a good mnemonic to keep in your mind, okay? The UKOSS is a little bit more complicated, but it's great when you start doing research. At the bedside, if you can remember this, you're going to help a lot of people, okay? Your differential is very quick. Acute myocardial infarction, anaphylactic shock, anesthetic accident, aspiration pneumonia, placental abruption. Now that's a weird one right there because there's only two things in obstetrics that usually gives you this massive of a DIC. Placental abruption and AFE. What do they have in common? They both result in the presentation of fetal placental tissue to the maternal vascular side, okay? Which happens every day and everybody we take care of, but some of these women have an inappropriate response to that stimulus. Pulmonary thromboembolism and then septic shock. Okay, this is the amniotic fluid embolism slide. Why I put it up there, there's some history here, okay? Remember in 1941, if you saw this, that meant you had an amniotic fluid embolism. There was a crazy guy who was actually president of the Society of Maternal Fetal Medicine. You've heard me talk about him a minute ago, Stephen Clark. Steve did, when he was a fellow, and then subsequently after that, was doing some research. And he's the guy who knows what normal pregnant women's pressures are, okay? Because he put Swan-Ganz catheters in normal women in the first, second, third trimester and immediate postpartum. Okay? These are volunteers. Then he put them in people who were critically ill, and you were able to profile that. So incredible work. But what he found was totally normal women during the delivery process, you have fetal squames and you have amniotic fluid and all these things that get exposed almost in every single delivery, but yet they don't have amniotic fluid embolism. So these findings can help support that diagnosis in women with classic symptoms. Okay? But if you have other things going on, just because you find this, that does not mean you had an amniotic fluid embolism. Okay? So treatment and management. Initially, I will tell you, this is the doorbell ringing. You're thinking, oh, it's Girl Scout time. They're bringing cookies to the door. You go to open the door, and this is a Sherman Army tank barreling down your driveway, getting ready to go running over your house. Okay? It is a very intimidating thing. This is not something you want to do by yourself. Okay? So this is a mass code event, and you want to solicit. And I will tell you, I've been doing it a long time. Every time we see this, or we see anything close to this, bad placental abruptions, I feel like Custer at his last stand, because you will take any help that you can get. Okay? You want to summons everybody there, to get things going. It's a massive code protocol, massive transfusion protocol, etc. These people can consume an inordinate amount of blood. Okay? I'm talking hundreds of units. So very, very complicated to take care of. But your initial approach, okay, CBC with platelets, fibrinogen, split products, PT, PTT, INR, type and cross. If you don't have that, just give O negative. Okay, you've got to fluid load these people. Give them some isotonic saline. Get a blood gas as a baseline. Here's one that's very important. People forget about. Mike Varner did this study, and I think it's 90 or 91. It's called hold a red top. Take a red top tube. This is a very poor man's way of doing this, but it works every single time. Okay? Take a red top, tape it, and tell a nurse to tell you when 5 minutes is up. Then you order your electrolytes, cardiac acid enzymes, EKG, chest x-ray, etc., echo if you think you've got some other things going on. 5 minutes is up. If there's a good clot, your fibrinogen is over 150. Okay? So you've got a little bit of time. Take a deep breath. If it's a semi-solid clot, your fibrinogen is around 100. You need to be getting stuff mobilized and getting some blood products up there. Okay? If it does not clot in 5 minutes, that means your fibrinogen is less than 100 and you're in big trouble. There's a thing now called liquid, I'm blanking here. Fresh liquid plasma. So there's FFP, that's good for a year. But you have to thaw it, takes 30, 45 minutes, okay? So liquid plasma basically is FFP, think of it that way, but it's not frozen, and it has a life of about 28 days. So you get clotting factors faster that way, okay? And when you invoke these massive transfusion protocols, that's a way of cheating to get things going faster for you. But that red top tube can help you, and that's one little simple thing that people forget. So treatment, again, is basically trying to support end organ damage and prevent that. So you're going to fluid load them, put on oxygen. The left ventricular failure, you're going to do inotropic support. Fetal management, okay, hopefully they're already delivered. Okay? If they're not, and you start the resuscitation, okay, this is CREOG questions for the residents. For those of you doing your research, this is important. If you are 4 minutes into this and you have not resuscitated, okay, and got mom back to where she's stable, or at least making some progress, you need to go ahead and do a C-section. Okay? At 5 minutes, the baby needs to be out, because that is the best data that shows intact survival. Okay? After that, doesn't mean you don't have intact survival, but the number starts going down. This comes from Katz and actually Steve Clark's data, where they looked at this, and you can see it 0 and 5 minutes. And these are for different indications, cardiac arrest, trauma, etc. Some of them are AFEs. But as you move progressively out in time, there's a higher percentage of non-intact survivals and then also mortality. Okay? So here's some things to ponder. There's folks who have tried case reports and have tried these on a one-off basis or a small series. It gives food for thought, but we're not ready to embrace these just yet. But basically putting them on a pump, cardiac bypass type surgery. Okay? There's some success with that. And all of these I'll submit to you are case report type stuff, so there's usually reporting bias. If I do something one time and it works, then I tell people about it. If I do something 10 times and it doesn't work, I'm probably not really inclined to tell you about that. So there's always reporting biases there. Hemofiltration, plasmapheresis, recombinant factor 7. Dr. Sanchez, or not Dr. Sanchez, but Dr. Torres. Sorry, Carlos, where are you? You're getting me mad at me here. Dr. Torres, when he was a resident, actually was with the team, Dr. Dart and them, when they had a liver rupture, and it was the first report of using recombinant 7 in a pregnant patient. We've used it. It continues to enjoy use. It does seem to have a increased incidence, at least in our experience and others, of having DVTs. Okay? But these are life-saving drugs, and they're catastrophic events. So recombinant 7 is one to keep up your sleeve. Nitric oxide, high-dose corticosteroids, with the thought being that you've got this inflammatory response, kind of like a septic response or anaphylactic response. So high-dose steroids are something to think about. There's Rob's back there. What's the new trauma drug? It's about $50,000. Kcentra. Kcentra is a new kid on the block. Stay tuned. It too may have a role here. Most of these things that we're talking about in this particular slide are last-ditch Hail Mary. Doug Flutie at his best. We are trying every single thing we can to save a life at this point. So this is something that I think that we can address, and this is simulation training. Numerous articles support the concept. It gives you the ability to do mass transfusions, cardiac arrests, perimortem C-sections, and all those. It's not necessarily tailored directly to AFE, but it gives you the skill acquisition and the ability to assess any deficits in a system so that you can improve that. Okay? So this is an area I think that can actually help improve things, and it's not that expensive, and they're widely available now. So we were talking earlier, somebody survives, they're never going to get pregnant again. I think Dr. Lewis was talking about a patient he had. Okay? Memory is short, okay? And we all get goo-goo eyes sometime down the road, and we forget how bad things can be sometimes. So these patients come back and ask then, what is the recurrence risk? In the world's literature, there's never been a recurrence. Okay? But just because you have 0 recurrences doesn't mean that it's 0 recurrences. So if you're counting a patient, the general rule, there's a statistical principle here. Basically, you tell these people it's about a 30% chance of recurrence. Okay? If you had Baha here doing the talk, he would say 50-50. Okay? Everything with Baha is 50-50. Okay? But for this one, from a statistical standpoint, it would be about 30%. Okay? So where are we going to go with this? I think the UK OS system is starting to gather data. Ross McQuivey and I were in London over the summer doing a lecture on postpartum hemorrhage. We had pretty much all the European postpartum hemorrhage experts there. We were doing kind of an international symposium, and they had a death that day. And we had some events the next day, and some of the doctors from the UK had to be checked out because immediately there's a 24-hour national evaluation on that hospital to see if there's anything they can do to improve things, etc. Okay? So this system has very strict criteria where they gather data and try to put it in a database so we can start to make sense of something that doesn't happen all that common. Okay? There's several others out there. I would like to put a plug in for the AFE Foundation. This is a nonprofit charity that exists for several reasons. One is to help encourage research, to help bring awareness, and most importantly, help families who seek out information and give them support. And we have a very special family here with us today that we're going to recognize in just a second. The AFE Foundation has also been very instrumental in establishing a worldwide registry at the Baylor College of Medicine in Houston, Texas. Dr. Dildy is the head of this. And the registry opened in August of 2013. The idea with the registry is to try to collect cases, abstract the charts to see if there's ways that we can identify some subsets. Is there a racial, a religion, a body habit, something? Is there something out there we're missing that could enhance our predictive values? They sort all of that out. Ultimately, and we do have, as I said, a family here with us today who has experienced the worst part of this. We're looking to get blood and placentas so we can start looking for A, diagnostic tools. Number 2, the ideal situation might be that we might be able to profile a mom. It could be as simple as I'm thinking about getting pregnant. We do your blood work, and maybe there's something there you can say, oh my gosh, you have a 50% chance or 25% chance. Maybe there's some genomic process there that we could help avert. Or if you do have that, maybe we could help prevent it. So I think the AFE Foundation, and they do take donations, is a wonderful thing to be part of. And Regional OB Consultants, Miranda, we're going to do $1,000 for you and for you being here with us and helping to try to find things to improve outcomes for patients. So in summary, our current concept is that there's an exposure to antigens that causes some type of a systemic response in the mother. It's a perverted reaction that's unpredictable, undiagnosable until it happens, and it's very acute and it's rare. Okay? That's the third time. Okay? So remember those. Treatment is nonspecific. It is generally supportive in nature to support the end organs and keep them damaged. the morbidity and mortality is large, okay, for both mom and baby. OB teams should be prepared for this by training with simulation, which addresses other issues that can occur. We need desperately better predictive tools and diagnostic tools to help prevent this and better understand this. And there are a lot of efforts underway at this point. So I will end there, and it is really, I think, for me, the highlight of my day is I get to introduce somebody. And I want to read this to you, and I know Miranda real well, but I just get mesmerized with what she's done. So Miranda Clausen is the executive director of the Amniotic Fluid Embolism Foundation, a nonprofit advocacy group that is dedicated for research, which she founded in 2008. She's responsible for the organization's overall business and marketing strategic plans and is the primary driver in overseeing its day-to-day operations. Miranda assisted in the development of the amniotic fluid embolism patient registry in collaboration with the Baylor College of Medicine in Houston, Texas. She's on several boards, including the Scripps Clinic, Division of the Scripps Health at the California Maternity Quality Care Collaborative at Stanford University. She's a very frequent guest speaker, panelist, and lecturer on amniotic fluid embolism, and is one of the greatest patient advocates around for this. She's contributed as an author on numerous research articles, including the most recently National Approved Safety Bundle, Patient, Family, and Staff Support after a severe maternal event. She's been recognized for numerous achievements, including People Magazine's Hero Among Us Award, for her dedication and commitment to helping address and combat a leading cause of maternal death and suffering. So I think when you hear that, you're like, wow, this is a really, really this incredible person. Well, I'm going to tell you another little story about Miranda. Miranda didn't do this because she knew about this and got interested in it. Okay? Miranda does this because she has love and passion in her heart, because there was a time when she didn't have anything in her heart. Miranda died from amniotic fluid embolism, and they were able to recover her. And through that experience, she sought out answers just like other families do, and she decided then and there, since there was nothing, from henceforth we shall have something. And that's been her lifelong ambition since then. She was a commercial banker before, and so she's given up her job, and this is her job and her lifelong passion. So it is an honor to have you here in Chattanooga, Tennessee with us today. Yeah.
Well, that was very kind. I have equal dear sentiments for this kind man for welcoming a patient. Typically, in an atmosphere like this, you don't necessarily get to hear the patient side of the story. And so let me just start first with saying thank you to all of you for being here, your commitment to your chosen profession, as well as your commitment to come here and learn. I know that it takes a lot of time out of your day to continue with continuing education, and I hope today that we'll be able to give a little bit of a different perspective, which is the patient perspective. As Dr. Adair, thank you so much, had sort of alluded to, thank you, is that, for years, there hasn't been a lot of hope. And as he had mentioned, coming home from having suffered this myself, and obviously the recovery process has been long. It's been almost 8 years, and I still have long-term medical complications as a result of the AFE. However, when you come home and find that there's nothing there to support not only you, but there's nothing there to support the staff as well. It didn't fall on deaf ears that I knew what had happened in my facility, a facility that had a great outcome, how devastating it was for our care team. I can't imagine what it's like for the care teams when the outcome is not positive. So with that said, I went to the library and I did a bunch of research, and I found Dr. Clark, Dr. Dildy, Dr. Adair, Roberto Romero at the NIH. I found a variety of individuals that had been involved in AFE research, and yet I had not seen anything that was very current other than what was coming out of the UK. I quickly was schooled on how different the United States is compared to other developing countries and developed countries, which is how we report these events. The US is very fractured. Every state, every county has different requirements, not only on death certificates, how you list a father on a birth certificate. And I don't think that until you hear it from the patient side, you understand what those ramifications are. For example, a woman dies during childbirth. She's not able to notify you who the father was, even though they did the pre-work. In the state of Tennessee, he's not next of kin. He doesn't get to take home his child if the child survives. How many of you here knew that that would exist, where a father of a child could not take home his child if mom dies during childbirth? One hand. When you realize that when you're wanting to take home your baby from the NICU and you can't, you need to get your mother-in-law or your father-in-law to sign off because they're the next of kin. Imagine what that does to a family. So with that very hearty information, there are so many instances like that. And so when I saw that these things were happening, I had to do something about it. One of the first families I connected with, the woman had passed away a week before my own AFE, and that immediately gave me the resolve to do something about it. And so while the road has been long and hard, the road also quickly, I just want to give a quick plug too, is that my husband had never stepped foot in a hospital before this had happened. This was his entry into parenthood and his entry into understanding medicine. Our lives were both entirely changed. He decided, when I decided that I wanted to start the foundation, he decided he wanted to become a nurse. He's now a charge ICU nurse in the same ICU where I delivered. So our lives have been very, very changed. And I want all of you to know that it's people like you who inspired us to do it. It was the ICU nurses, it was the NICU nurses, it was our labor and delivery nurses who inspired us to do something different. So if you guys have a hard day, or you guys have a situation that hasn't gone right, just know, though, that there are many patients who value what you do. And most of the time it's a positive outcome, but there are many times when it's not a positive outcome. So we're here to support families, and we're also here to support you as clinicians. So we're talking about how AFE, there's a new hope on the horizon. As I shared with you, the impact of AFE, it's extremely, Dr. Adair, and I won't keep us too long, but it is extremely difficult to determine those rates in the U.S. because we are so fractured and we have different reporting requirements for every state and every county. We call us 1 in 40,000. You know, the numbers are so skewed, and the reason is because there's poor reporting. But we believe that through most of the literature that we're seeing, it's somewhere between 1 in 40 and 1 in 50,000. It is a leading cause of maternal death in the U.S., 40-60% maternal mortality rate. 20% fetal mortality rate. But I'm sure many of you have seen, if you've been in any kind of seminars where you talk about maternal death, then they show you the picture of the iceberg, and it's just the tip of the iceberg. Imagine all the people that are underneath that. And that's the morbidity, and that's what happens after maternal death. It's this ripple effect. It has lifelong and lasting impact on not only the families, but also on care teams. We've lost care providers from suicide from this. They have become a second victim. We have people who leave the industry altogether who can't come back. We have people who suffer from PTSD. It's very real, and it's potential harm for you. And so we're here to help support you, and I'll share a little bit more about what we do. So we're a nonprofit. We were started in 2008. Dr. Adair already shared you with our key initiatives, which is promoting, advancing research, promoting awareness and education, and supporting families. So here's what we do to, oh wow, I have the same outfit on, look at that. I like this outfit. That's the first thing that popped up. Oh dear. Fashion is not my thing. Saving mommies and babies is. In 2013, we were able to finally put together, this was many, many years in the making, was to put together a registry. We knew that we wanted to do clinical research. Something that's very passionate to me is I want to do clinical research. It's very challenging to do clinical research. How do we do clinical research? Well, we needed to start somewhere, so we started with a registry. And what that registry is it's actually self-reported cases of anybody who has been diagnosed, prognosed, anybody who's had a potential AFE, is they are able to self-diagnose or self-report them into our registry. We then consent them through an IRB process and get all their medical records, their prenatal records, and their post-discharge records, as well as autopsy records and personal health history. So that's a retrospective data, and what we're looking for there is to look for incidence rates and give better information than what we've seen out there. We do have the largest registry ever in the world. It's an international registry, so we're taking cases from all over the world. What's unique about this registry too, though, is that it's also looking at subsequent pregnancies, as Dr. Adair had spoken. We are very excited about entering into a prospective registry, and that prospective registry is with Roberto Romero at the NIH, and we're in collaboration and IRB process to go through that, which is very exciting, which is looking at serum samples and being able to consent families right on the spot. We typically hear of an AFE case within about 24 hours. Families usually reach out to us through our website, and that's how we're getting a lot of this data and information. And as I said, this registry will be used as a database for us to go back and do clinical registry and looking at, or clinical research and looking at genomics on those who have survived, as well as looking at genomics on husband and children if we've lost a loved one. Promoting awareness and education. Whew, I'm so glad that's not the same dress in that picture. I was actually getting worried about that. We are very active in a variety of societies. Society for Maternal Fetal Medicine, I'm very pleased to say that we just had our first published abstract that we were able to present in a poster session just about 8 or 9 days ago. We're also involved in ACOG, AWAN. I'm fortunate to sit on the board of the California Maternal Quality Care Collaborative, and what that's doing in the state of California is really working hard on toolkits and safety bundles and pushing those out, and also engaging patients. So my role there is to always give the patient perspective. And also the Society for OBGY, or Society for Obstetrics and Gynecologist Hospitalist Program, which are those brave individuals who no longer want to take patients but want to stay in a unit and be there 24/7 to hopefully work on the emergent cases, and a great example of an emergent case is an AFE. We participate in doing clinical meetings, as I said, presenting posters or giving presentations, grand rounds, CME events such as this, and promoting our research, simulation, and drills. If any of you are interested in having us come to your facility, we would be happy to provide you with any of that information or come do it with you. Also, we've become very involved with the AIM, which is the kind of cohort of the patient council for the Council for Patient Safety and Women's Health. And what that is I don't know if you guys understand what the council is, but it's an overarching where all the other associations kind of roll up into this, and they put together toolkits and safety bundles. And what was very passionate to me, as I had shared earlier, was caring for not only our patients, but also caring for the staff. And so this safety bundle, you can all access it. Either I have copies of a portion of the bundle out in the lobby, but also what this does is it talks about HIPAA. It talks about what you need to do in a severe maternal event. And one of the things I'm most proud of, and you guys can use this anytime, not just with AFE, it's for any severe maternal event, but we developed a clinical summary. What happens to your patient once you're done seeing them? Let's say they are fortunate to survive a severe maternal event. What happens to them when they leave your doors? A lot of times they don't know what's happened to them. They've extremely traumatized. They have a lot of medication usually in them, and they're extremely hormonal. So with that being said, we've created a fantastic patient clinical summary. You can complete this and share with them what exactly transpired during their time with you, and they can take this for continuity of care. And then also in the safety bundle is how do we care for the staff? How do we reduce second victimization? There's a great literature review, as well as how to debrief and how to set up a protocol. So if you don't have this in your units, I would highly suggest you guys look at this safety bundle and talk about what are you going to do when something does happen. So Dr. Adair and the clinical team can tell you how to support a patient of AFE or severe postpartum hemorrhage, eclamptic, cardiomyopathy, any of those things. They can tell you the hows, the whats, the whens. We tell you through this safety bundle is how do we take care of you. If you don't have a process in place for when something bad happens for your staff, you need to develop one. We also have created an international awareness campaign, so you'll see some of us today wearing ribbons. If you don't have a ribbon, please stop by our booth. We'd love to give you a ribbon. Our awareness day happens to fall on Easter this year. It's on March 27th. It's a day where we recognize that this entity exists, and we ask others to share their stories, including care providers. Offering support. This is by far one of my favorite pictures. Offering support comes... It was the primary precursor to starting the organization, was how are we going to support families. There was nothing for families to connect to. we now are able to connect. We have 350 families within our support groups from all over the world. You would think that even if they didn't speak English, how could they possibly join? Facebook is a wonderful thing. Love it or hate it, it has provided a great deal of comfort and support for people all over the world, and they have a little translate button. So we have two women from the Isle of Man who were able to connect. The Isle of Man has like 10,000 people, and 2 people have had an AFE. They were really able to connect and get together. We have people from, again, all over the world, and it's a beautiful sight to see, even though we're all in there and we're all suffering, but to be able to connect those patients to one another. But we also have support groups for clinicians as well, which is how to talk to one another and share without fear of any kind of retribution or judgment. We have outcome-specific support groups. So we have support groups specifically for survivors. We have those of survivors who are wanting to go on and have more children. We have a support group specifically for widowers that's different than grieving families. And we also have one for care providers. We do crisis intervention. We also offer helpful guides and resources on our website. You have this happen in your facility, please call us. 24/7, you can call us. Middle of the night, you can call us. We will be there. We will make our best to either have someone there at the facility, or we'll walk you through things on the phone. As Dr. Adair had said, trying to find a gold standard, we do believe there are some quick things that you can do with blood and serum that you can look for. And we're hoping that once we have that prospective registry, we'll be able to give those verbally over the phone. We also build a lot of bridges with risk management. Anytime there's a severe maternal event or a loss, we automatically want to point a finger. That's human nature. Most of the time, are there areas for improvement? About 99% of the time, there's an area for improvement. Doesn't mean that everybody here took an oath and to err is human. However, we build bridges between risk management when risk management comes in and says, let's not talk about this. Let's just go back and look at our documentation. Go make sure you make your notes. The human. Our nature is to connect, especially there's many women in the room, but typically how we get support is by talking and connecting with other people where we feel empathy and sympathy. To shut down communication is detrimental to not only your staff, but also to the family. We have found that most families that come to us do not seek any kind of legal action because we're able to answer the questions, because when you tell a family in the middle of trauma, they don't even know what you've said. They're not going to remember it. They're going to remember the mundane things. What temperature was it outside? They'll remember hearing the code being called. They'll remember, they won't remember what you look like. You're in scrubs, you have a mask, you have a hat on. They won't remember very much. So what we do is we help educate them and help tell them exactly what happened. And then we try and build bridges, and we try and say, hey, let's connect back with that family 3 weeks later, 6 weeks later. Let's check in on them in 3 months. 6 months, and a year. Oftentimes what happens is the patient leaves your facility 6 weeks. If she survives, 6 weeks she'll go back and see her OB. What happens when we lose a mother? Is anybody checking in on dad? And we found that with the social worker and with some of the care team, that if you're able to stay connected, that relationship, and there is a great amount of healing. How can you stay connected with us? We're all on social media. Everybody loves social media. So we're on all the main social media sites, and we would love for you to follow us if you so choose. And this is a motto that I wholeheartedly live by, which is, an event had happened upon which it's difficult to speak and impossible to be silent. And that stands for not only us as patients, but also you as providers. It's very difficult to talk, and I'm about to unfortunately talk about a situation that's extremely difficult. Many of you may be involved. Raise your hand if you're here from McMinnville. Okay, wonderful. Thank you for joining us. We have a lovely patient, Miss Whitney, and her family is here with us today. And Whitney was anxiously awaiting the arrival of her daughter, Phoenix. Anybody who knows Whitney would say all she wanted to do was be a mom. And her fiance Saul were very, very excited about their baby. And you can go back and look on our Facebook pages, and it was just, I love you already, you are my sunshine. I mean, she could not wait to see this precious baby. Unfortunately, the worst happened, and she suffered from an amniotic fluid embolism. She's at a rural facility. We know that many times when these happen in rural facilities, sometimes they don't have everything that they need. But even when you have everything you need, sometimes it's not enough. And in that situation, Whitney was cared for at the team at McMinnville, and then she was quickly transferred here to UT Erlanger. On this picture, you'll notice we have special guests with us. We have Whitney's family here with us. And the reason why we brought them here today is to give you not this sad story, but we came here to give you very practical application for what we're talking about and how our organization works with families. We were quickly notified, not only on the clinical side from UT, but we were also notified by the family of Whitney's passing. We were immediately talking with her sister, Jessica. We were immediately talking with the care team. It was an unfortunate, very unfortunate and devastating situation. But the reason why they're here today is because in the midst of all of their grief and all of their sadness, Dr. Adair pulled them aside and said, listen, I am so sorry this happened. We did everything we could, but there's something that you can do to create a legacy for your daughter. There's research. It's a really, really difficult conversation to have. And this family immediately knew the heart of Whitney. If you ask any of them, they will tell you she'd give you the shirt off her back. She'd give you her food. She was quite a character, I know. I've seen her Facebook page and I know her family. She was a loving individual, and what she would never want is another woman to go through what she went through. So they did the most loving thing. We had just had an IRB approved to collect serum and samples. Whitney is our very first sample. We have her serum and her samples. She was also an organ donor. Her legacy will continue through the research that we're going to do on that. And I pray to God that we get answers from it, and it's not in vain. But I believe that we will get answers from it, and there is hope. And so to acknowledge the gift that you guys gave, we have, so if you're here from McMinnville and you're here from UT, let me grab, if you were part of Whitney's team, were you part of Whitney's team at McMinnville? Okay. Is there anybody here from McMinnville who was part of Whitney's team? No, but would you please join us, because we have something for the hospital. And then if I can also get the team, obviously Dr. Adair, Dr. Hamilton, Dr. Kaiser, and Dr. Bossert, could you join us, please? So these amazing individuals were a part of the transfer team as Whitney arrived to the emergency room, and they pulled out every last-ditch effort they could. Remember that super expensive drug that Dr. Adair was asking about? Whitney got that too. They did everything they could. But God's call for Whitney was stronger than our physician's hands, and so Whitney has passed. But again, so what we've done is we'd like to acknowledge your amazing efforts and your ability to connect with the family. And what we have is we have 3 trees that were donated to us from the Bar Nursery. These trees are beautiful trees. There is a dogwood tree, which has a great deal of religious symbolization. There's a cherry tree. Whitney's favorite color was pink. And I just think that her precious daughter, Phoenix, who was well, let me forget, see that's the picture of little Phoenix. Phoenix rose from the ashes, and Phoenix is the most precious little one. She finally fell asleep. She finally got tuckered. We have a cherry tree, and we also have a rising sun red bud. And I think that these 3 beautiful trees will be planted in her honor. So 1 tree for the family, and you guys can choose which tree you would like. And then we'd like to offer a tree for UT as well as River Park and McMinnville to have a tree, and please plant it in her honor so that her legacy continues to shade and to create a place of refuge. So. And then I just wanted to share one other thing that's really touching about our organization. When this happens, it changes. It's a ripple in a pond, and it affects everyone. And we had a wonderful woman who lost her sister. And she thought, how in the world am I going to tell my niece that the day of her birth is also the day of her mom's death? How do we talk about that? And so she was a beautiful writer, and she wrote a book, and it's called The Wonderful Gift. And The Wonderful Gift is about an angel that was in heaven. And she was doing so well. She was such a good angel. But God said, you know what, I'm going to send you to earth. And so she came to earth, and she had an earthly family, and she did lots of great things. And she was wild and crazy, just like Whitney. And one day God called her back and said, you know what, I need you back in heaven. But I'll do you a favor. I'm going to let you leave a gift. And you can think about it. And so she thought and she thought and she thought about what kind of gift can I leave behind. And finally God said, you know what, I'll help you make this decision. I'll help you with the gift. It's only a gift that I can help create. And so the day that she left to go back to heaven is the day that she left her angel baby. And so this book, I would like to offer also to the families, as well as if anyone's interested in having this book, I will send it to you. I'm not here trying to sell the book, but it's a beautiful book that can often tell. And I know it's a faith-based book, but it's a wonderful book, and it's something that can be used to help read this to Phoenix as she gets older. So if you would please join me in just giving a warm welcome to these families and thanking them for seeing what we're doing, and also for the care teams for all that they did. So thank you very much. Thank you all. So Saul, if you would just raise your hand. Saul, Whitney's fiance.